Now let's talk about lipid-lowering drugs. HMG-CoA, reductase inhibitors, statins, are the most important lipid-lowering drugs. They are very effective in lowering total and LDL cholesterol and have been shown to reduce coronary events and total mortality. They have few side effects and are now usually the drugs of first choice. HMG-CoA, reductase inhibitors block the synthesis of cholesterol in the liver, which takes up most of the drug. This stimulates the expression of more enzyme, tending to restore cholesterol synthesis to normal even in the presence of the drug. However, this compensatory effect is incomplete, and the reduction of cholesterol in the hepatocytes leads to an increased expression of LDL receptors, which increases the clearance of cholesterol from the plasma. Strong evidence that the statins lower plasma cholesterol, mainly by increasing the number of LDL receptors, is provided by the failure of the drugs to work in patients with homozygous familial hypercholesterolemia who have no LDL receptors. Adverse effects are rare, the main one being myopathy. The incidence of myopathy is increased in patients given combined therapy with nicotinic acid or fibrates. Statins should not be given during pregnancy because cholesterol is essential for normal fetal development. Because anion exchange resins do not work in patients with homozygous familial hypercholesterolemia, it seems that increased expression of hepatic LDL receptors is the main mechanism by which resins lower plasma cholesterol. Anion exchange resins, cholestyramine and cholestyramine are powders taken with liquid. They increase the excretion of bile acids, causing more cholesterol to be converted to bile acids. Adverse effects are confined to the gut because the resins are not absorbed. These effects include bloating, abdominal discomfort, diarrhea, and constipation. Nicotinic acid reduces the release of VLDL and therefore lowers plasma triglycerides by 30 to 50%. It also lowers cholesterol by 10 to 20% and increases HDL. Nicotinic acid was the first lipid-lowering drug to reduce overall mortality in patients with coronary artery disease, but its use is limited by unwanted effects, which include prostaglandin-mediated flushing, dizziness, and palpitations. Nicotinic acid is now almost never used. Fibrates, for example gemfibrozole, bezafibrate, produce a modest decrease in LDL, about 10%, and increase in HDL, about 10%. Moreover, they cause a marked fall in plasma triglycerides, about 30%. Fibrates are first-line drugs in patients with very high plasma triglyceride levels who are at risk of pancreatitis. All the fibrates can cause a myositis-like syndrome. The incidence of myositis is increased by concurrent use of HMG-CoA inhibitors, and such combinations should be used with caution. Inhibitors of intestinal cholesterol absorption. Ezetimibe reduces cholesterol and finasterol absorption and decreases LDL cholesterol by about 18% with little change in HDL cholesterol. It may be synergistic with statins and is therefore a good choice for combination therapy. Now let's discuss about drug combinations. Severe hyperlipidemia cannot always be controlled with a single drug, and combination therapy is increasingly being used to achieve target lipid levels. Combinations should involve drugs with different mechanisms of action, for example, a statin with a fibrate. Although the combination of statins with fibrates and nicotinic acid may increase the incidence of myopathy, it is increasingly believed that the benefit of lowering LDL cholesterol in these patients outweighs the small increase in the risk of adverse effects. Interest in fibrates has been increased by a recent trial showing that gemfibrozole reduced myocardial infarction, stroke, and overall mortality in men with coronary artery disease associated with low HDL cholesterol. The drug increased HDL cholesterol without decreasing LDL cholesterol. So that was all for today. Keep following sqadia.com for more such videos.